Jenny's involved in urology oncology. She's a clinical nurse specialist at the Taranaki Base Hospital, but she's also involved nationally with the Prostate Cancer Foundation and does a lot of good work behind the scenes there. She's on the board and so plays a key role in advising that body from the clinical perspective, which is fantastic to have, right? So Jenny sees a lot of the men locally here in Taranaki and has supported many people, spoken at our local groups and so forth. So Jenny is going to cover a very real topic for literally thousands of men throughout the country with regard to erectile dysfunction, and that can take many forms and various steps from not functioning through to getting function back. So Jenny, well done for getting up here.
So we're talking about my PowerPoint. I haven't had an opportunity to update it. I wanted to take prostate cancer treatments out of that and just talk about cancer treatments basically. This talk is about, this slideshow is about prostate cancer specific. However, I think anybody with any abdominal surgery that's affected their erectile function would be given the same advice. So whilst I talk generally about prostate cancer, please do fire any questions at me about bowel or other related erectile dysfunction. I'm not an expert on this subject. I've just found myself having to talk about this a lot through my work. So this is what I know about erectile dysfunction.
If you click on it, if you want to go down.
I feel like the only way to talk about this sort of subject is to really talk about it, and I maybe sometimes say too much, I don't know, but I'm sorry if I offend anybody. So let's talk about the anatomy of erections. Can you see my mouse? Yeah. So this is a penis, obviously, and we've got the main bits, the corpora cavernosa here. These two bits, and these are the bits that are sponge-like, and these are the bits of the anatomy that engorge with blood when you have an erection. This is really important to keep these tissues healthy, and I'll talk more about that later. The nerves around here provide, the yellow ones are the nerves, they provide sensation. And just for reference later on, those nerves don't generally get damaged or shouldn't get damaged when you have prostatectomy. Those sensation nerves remain intact generally. To have an erection, you need three things, and you need all three of these things for a natural erection. And this is really important because any one of these things not working will stop you from having an erection. So you need your brain switched on. You need to be having thoughts, feelings, some kind of stimulation, because that's going to trigger the nerves to send chemical messages to the blood vessels of the penis. So without nerves, you also can't get an erection because you're not going to get the messages down to the blood vessels to know what to do. And then if you've got the thoughts and the feelings and the sensations and the nerves are working, but you've got a very poor blood supply and your arteries or your heart aren't working very well, then that's another reason you may not get a natural erection. When you have an erection, the arteries relax and let more blood into the corpora cavernosa, and then the veins close, trapping that blood in there. And if you don't have the thoughts and feelings, and you don't have the nerve sending those signals all the way down, you won't have an erection. So causes of erectile dysfunction, and this is in the general population, are multiple and many. People talk about it being a normal consequence of aging, and yes and no. If you stay very well and healthy, you can have good erections, well into your 90s. But when your body starts to be less well for multiple reasons, then the erections can be affected. So cardiovascular disease is the biggest one, or one of the biggest ones. So when a man who goes to the GP asking about, can he have the little blue pill, the GP's senses will look at his cardiovascular functioning, because erectile problems are actually the first sign of cardiac disease, and hypertension and atherosclerosis are things that will cause erectile problems. So GPs are very interested in following up your cardiac health if you go to them about wanting some Viagra. Diabetes is another one. Obesity makes a difference. Hormonal levels with testosterone and different things like that, hormonal, and that counts diabetes in that as well. Neurological problems, multiple sclerosis, stroke, spinal injury, those things will make a difference. Medication, there's many medications that will affect the erectile function. Antidepressants and blood pressure tablets, and a lot of your heavier pain medications will have an effect. Surgery, any surgery in the abdomen can cause some problems with the nerves. Generally, surgeries outside of prostatectomy will stun the nerves more so than sever them, if you like, and have more chance of the erectile function returning. But prostatectomy is whilst we get some erectile function back, it is probably, I guess, the most likely to damage it more permanently in some people. Depression is a big one, and substance abuse and alcohol and smoking. The smoking is related to the cardiovascular disease, I think probably more than anything. So if you have surgery for cancer and you have already problems with some of these things, and your erectile function already isn't very good, obviously the surgery is not going to make things better. Or, plays a role in how well that erectile function returns. So with prostatectomy specifically, some of the sexual side effects of prostatectomy, many of these aren't really discussed with patients. I've heard they should be, but they're not always. So loss of erections obviously is the big one. You can have some penile shortening, absence of ejaculation, urinary incontinence, and that's during intercourse. Damage is instant with prostatectomy, and it may or may improve, and that's one of the differences between prostatectomy and radiation, which I'll get to. You can have nerve sparing or non-nerve sparing surgery, and if you, I don't know how much time I've got actually to know how far into these things to talk, so perhaps I'll go
This is quite a
through
good one
this one.
to cover, yeah.
Okay, so when you've got prostate cancer, you'll have had an MRI and you'll have had a biopsy, presumably, and those things together help the urologist know where the cancer is. Some people have just one spot of cancer in one area, and some people have a lot of cancer throughout the prostate. So this makes a big difference on whether they can or can't spare the nerves. So if your cancer is sitting on the very edge or the outside of your prostate, then that makes it more risky to try and save the nerves. The nerves sit, I'll show you with my model. I've got my bag of tricks here. So can you see this? The nerves sit here.
Yeah.
This is an old model that's falling to bits, but the yellow bits are the nerves. So the doctor has to peel those nerves away from the prostate to save them. So if your prostate cancer is anywhere near those nerves, it would be not a good idea to try and save the nerves and risk leaving some cancer behind. So sometimes the nerves can't be spared. It's too dangerous. Other times, if the cancer, if they know there's a small amount of cancer and it's near the middle of the prostate, they might do a non-nerve sparing, which will give you a much better chance of getting your erectile function back. Sometimes they will save the nerves on one side. So if they know from the biopsy and the MRI that there's cancer on one side only, they will try to save the nerves on the side where there's no prostate cancer, and that gives, you know, some more chance of getting erectile function back. And sometimes they don't even try to save the nerves if it's too high risk. And we do occasionally see someone with a completely non-nerve sparing operation get some erectile function back. It's something that time tells us, really. It's often almost impossible to know who will and who won't. Prostate anatomy. So here you can see those are the nerves there that are going around the bowel, and you will see there's the neurovascular bundle is just here, and these nerves here are the nerves wrapping around the prostate. So you can also see how close this is the red bit's the prostate, how close that is to the bowel, how the urethra runs right through the middle of it, and the bladder, it sits above there. So, you know, there are possibilities of damaging all of those structures potentially. And you'll see when they take the prostate out, they'll cut it at the base of the prostate and they'll cut it at the base of the bladder. The urethra that runs through it will go with the prostate. So you will get some penile shortening. And there are some studies that say that not all men's urethras are the same length, and people with the longer length of urethra tend to have better outcomes. Probably not that interesting of fact, but there are some studies that show that. So ejaculation. So when the prostate, actually I'll go back. So when you have a prostatectomy, all of this prostate is gone. This white bit here is the seminal vesicle, and that goes as well. The tubes from the testicles, the vas deferens that comes up here, that's cut and left there. So the sperm is made in the testicles and it travels up through that cord, and that's disconnected, so it no longer has anywhere to go. So you are rendered infertile for that reason. But also the prostate itself, the job of the prostate is to make the seminal fluid, and along with the seminal vesicles. So when you ejaculate, normally the sperm comes up here and it mixes with the fluid from the seminal vesicles and comes out through the urethra. So when you take all of this out, you basically lose that whole function, which is why there's no ejaculatory fluid. If you do get some fluid with an orgasm after prostatectomy, it's probably urine, which isn't really a big problem. It's just different. So men, just out of interest, who've had TURP, which is usually for problems peeing and not so much for cancer, they have what we call retrograde ejaculation, where they still have some ejaculatory fluid, but often it goes back up and into the bladder, so you sometimes don't see it. Just out of interest. I think that was all I had to say about that.
So when that's because of the prostate swelling, right? As you get older. So does it close up on the urinary tube, and it also must close up then on the other tube coming through? Is that why it kind of ends up?
When you have a TURP, a transurethral resection of the prostate, it damages the little muscle up here, and partly your prostate itself wrapping around the urethra is like another sphincter, if you like, because it's, if you imagine a hose on the ground, a soft hose, if you've got pressure against it, it'll lie flat.
Yeah.
If you don't have pressure against it, it's a big hole. So your urethra is like that. When you have a prostate, it's got some pressure against it. So when you don't have a prostate, it's just kind of like a hose that's open. Right. So when you ejaculate, when you have a prostate, there's a little closing off valve there that often gets damaged with the TURP, and that's why that goes back up that way. Yeah. It doesn't happen to everyone, but it is pretty common. So with radiation, the difference between radiation and prostatectomy, in the simplest terms, is that with prostatectomy, the damage is done immediately, and we aim to improve things. And with radiation, it's a damage that happens more slowly. And I was reading about it today, and there are very conflicting articles about this. Some say 2 to 3 years you'll start noticing a decrease in erectile function. Some say 5+ years. So basically, the radiation does some damage to the nerve fibers, and it damages the blood vessels, so that it's harder for the erectile nerves to get good, to stay good and healthy, and for the blood vessels supplying them to get all of, the good healthy blood there. And radiation damage is kind of like the gift that keeps on giving, if you like. It's like a long, slow onset. So on here I've put over a few months to years, but when you look at the literature, it can say anything from a few months to 5+ years. I think it happens a little quicker than 5 years, and like surgery, depends on how good the function and the health was prior.
So Jenny, just on that, some men obviously have removal, and they might have nerves sparing both sides or one side, and then they have radiation, and so that's like a double whammy almost, isn't it?
Yeah, and then you add some Zoladex, some ADT for that, and it's a triple whammy.
Yeah.
So these days with radiation, you often get androgen deprivation therapy, which is the Zoladex injections, which removes your testosterone. So when you don't have testosterone, that reduces your libido quite significantly, as well as it can cause depression. It gives you less energy, makes you more moody, and all sorts of side effects that come along with Zoladex injections. And so that's just another way of making the erectile function a little less normal, I guess.
Jenny, can I ask a question on that?
Sure.
I've done a little bit of reading on this as someone who's had radiotherapy, and one of the things I read was that at around sort of 2 to 3 years, you get to a point after radiation where most of the damage from the radiotherapy is done, and then from that point on, it turns into more of a natural kind of a decrease in function. Is that similar to what you've heard, or do you think that the radiation damage actually is an accelerated damage for the rest of your life?
This isn't my area of expertise, radiation. Generally, my own patients that have radiation, I often never see them again. So I have no personal experience in seeing for myself the outcomes. But from what I've read, it's a continuous ongoing deterioration. I could be wrong. I can't find literature that agrees with, that sings from the same hymn sheet on this subject. What I will say is that I believe that I think they should be teaching more, what do I call it, penile rehab for radiation, and I think that's not very well done, and it should be, because I think, it's the whole use it or lose it thing, that if people are encouraged to do penile rehab like we do with prostatectomy, I think people would maintain a better erectile function for longer. But I think, like surgery, even if you retain your erectile function, it's probably not going to be as good as it was. But I think that can be something we accept as an age-related thing as well as, accept maybe isn't the right word, but, it's something that we see through the lifespan. But I do think penile rehab, which we'll get to, is a good idea, as good for radiation as it is for post-prostatectomy. The trouble is that with prostatectomy, you know immediately that you've got no erectile function and you want to fix that. With radiation, it's preparing for the future, so not everybody's motivated to do it, and I kind of get it. Yeah, so just for an explanation of radiation, it's very, very difficult to give radiation without damaging the surrounding areas. So this picture shows that what they do is when you look at this one, they're putting radiation in from many different directions so that they get lots of damage to the prostate with as little as they can to the surrounding areas. But of course, the nerves sit right on top of the prostate, so they can't avoid them. They can't, they can't avoid the bowel, they can't avoid the bladder, or the base of the bladder anyway. So this is why we get the side effects that we get from radiation. But they do actually do a really good job of, minimizing the damage to the surrounding areas. And I certainly hear, you would probably hear the same. I think people are coming out of radiation these days are actually really quite well, in my experience.
Yeah, well, we had Claire Hardy on, and she talked about less doses but stronger.
Yeah.
And it's not a multiplying factor. If you do it, give it stronger, then you don't need, the same quantity. But they're starting now with these new machines. They can be very, very specific.
Yeah.
Yeah.
And if you've just got one small area, I think they can do a much more, they don't have to radiate the whole thing, but it's a very, very fast developing area. So I've already really talked about that. When you have radiation, you often have to have ADT as well, and that just makes everything that much harder. for many people having radiation, the ADT, the Zoladex injections are only usually a year to 18 months post-radiation, usually. Certainly if it's a curative intent radiation, but still that can be also a number of months following completing the course, that it'll take a long time for the testosterone to recover.
Yeah,
okay.
I think if I recall, it can be longer than a year.
Yeah,
You
I
know,
think
for
it's
some.
sometimes 18 months on it, and then a year plus.
Yeah, to recover.
Yeah.
Yeah, if I can interject, yeah, I had 2 years of ADT, and I'm still having after effects now 3 years later.
Right.
So it's just talking to the specialist. It can be a year, it can be 2, 3, 4. It's one of those. I mean, I still have hot sweats, etc. Unfortunately, I had a triple whammy because I had chemotherapy as well as I've had all three.
Wow.
And you're talking about the radiotherapy, that seems to answer a lot of questions that I've got, because things weren't too bad. I didn't have a prostatectomy because it's gone seminal glands, and I've got grade 4, so it's actually gone through. And I didn't really have too much of a problem with erectile dysfunction, but as time has gone on, it's slowly got worse, and that now has answered a few questions for me when it comes to the radiotherapy thing.
Yeah, I think it, for some people it gets quickly worse, and for others it's a slow, it's naturally the erectile function does slow down, and the desire and all of those things do slow down through the decades, but radiation certainly hastens that natural decrease.
Or the desire's there, but it's just not working as well as it used to.
Yeah. I think desire too, though maybe it's not so much desire, but as you age and your testosterone reduces as you age naturally, I often think of it like when you're a teenager, when you're a young adult, you get the urge and you'll act on that urge. It doesn't matter what's going on at the time. If you're in the middle of a movie and you get the urge, you'll follow that and go back to the movie later. Whereas when you're older, you get the urge and then you finish watching the movie and the urge is gone, sort of thing. You're less inclined to be as quick as you were when you were 20 to put that into action. And I think that's a natural thing that comes with a lessening of testosterone, and certainly having ADT will do the same thing, only to a higher level.
Yeah.
Yeah. So and a lot of people think because the urge, the desire, not the desire, that urge from, I'm not using my words properly, but because you're on testosterone and you have a decreased, what's the word I'm looking for? Desire. I think a lot of medical people think that makes it okay, that, oh, well, you're not going to miss the erectile function because you're not having the same urges that you were having because you're on ADT.
Yeah.
And I think people mistakenly believe that, and that's a little bit of a shame, and we do need, I think patients need to tell us medical professionals when we're doing a bad job, and as much as no one wants to hear that, it can change your practice when somebody pulls you up on an attitude that perhaps isn't right, because sometimes we don't know any better. But anyway, the good news, I'm probably taking too long.
No, there's
sorry.
the clock up there.
Okay.
Again, okay.
So there's lots of treatments available, so that's a good thing. We'll get to that. the sensation remains. Remember I said earlier, those nerves that provide sensation are still there. So if you can't get an erection, you can still have an orgasm, and it still feels nice to play with. And I actually encourage a lot of my patients to, post prostatectomy, to play with it in the shower or whatever, and because I think you can encourage some of that sensation and some of the nerve synapses and things like that. If they're coming back, I think it helps, and it's just good to know that all isn't lost. And the other thing is that intimacy isn't dependent on erectile function, and a lot of people realize that, but a lot of people actually don't, and a lot of men, I find in my experience, certainly not all, but a lot of men think that this is how women see their worth as a man, and that's certainly not true. And I often say to my patients, if you were to ask your wife or your partner to list all of the things that make you a man in her eyes, she's probably not going to put erectile function on that list potentially at all. She's going to say that you make her feel safe, that you're a good provider, that you're there for her, that you lift heavy things and you look after the lawns, and you make her feel good, and she enjoys your company. And those are the things I would put money on. Those are the sorts of things she would write on her list. And I've said that to patients before, and a couple of times I've had men have a real light bulb moment and actually realize, okay, this isn't the end of me as a man. It certainly isn't. But I do understand it's a difficult time. Women don't miss the ejaculation. That's a good thing for many people. There's a lot of ways to have intimacy together as a couple without an erection, and there's lots of ways, and I talk to patients about that stuff often, whether they want to or not. But it's a healthy thing to know, and it helps while it can take 2 years to get the erectile function back, and it's a really long time, and it's a real time where you need to have patience with yourself and humility, and if you've got a partner with whom you can have a laugh with and not take yourself too seriously, I think it really helps. While it is serious, it just helps not to take it too seriously, and because there's going to be failure, there's going to be attempts to you might end up getting a partial erection, and you try and use it and that fails, and if you can have some sort of fun with that and make it work for you, that those sorts of people, I think, do better in some ways because they are able to have the patience to wait and do what's needed to be done to make the penile rehab work to its best.
I was just going to say, that most of you guys will find that that 2 years kind of after an operation, you're dealing with managing potentially leaking still. So it's not just a penile erection, you've got continence management, you're going through your head around anxiety and blood tests, and all there's like a whole lot of stuff happening all at the same time, and I think it's it's a lot to take in, and so some of that will weigh in on the fact of the erection stuff, is because you got all of this other stuff that you're trying to deal with as well.
Yeah, and I think it's a really interesting statistic that people with any kind of cancer are 4 times more likely to be depressed than the general population. and the general population is pretty depressed
Yeah.
these days. So, you know, it's quite normal for this to be a really difficult time.
Yeah.
Just having cancer alone puts you in a bad space. But then the studies also show that people with urology cancers are 4 times more likely to be depressed again than other cancers.
Wow.
And I think that's because of the incontinence and the erectile function, you know, along with all the other things that having cancer brings. So, you know, that's a really important thing, you know, to be patient with yourself and be kind to yourself about at this time. And have patience, because sometimes it's less about the actual ability to have an erection and more about your mental space. So after you've had a prostatectomy, and I would think after radiation as well, but I only deal with prostatectomy, so I'm just going to talk about that, but I think it stands for radiation as well, for those that are motivated to do it. So penile rehabilitation is really all about trying to keep the penile tissues healthy while we wait for the nerve supply to come back. So after surgery or radiation, actually, I'll just talk about surgery. So after surgery, remember I said you need the 3 things to have an erection? Well, after surgery, you're going to have the thoughts and the feelings, you're going to have the blood supply, but you're not going to have the nerve supply. So what we need to do is keep the blood, the corpora cavernosa, which is the big vessels that swell up when you have an erection. We need to keep those areas healthy. Well, if we wait for 2 years and there's no blood flow through the, you know, those sponges are going to not work as well. So we want to keep them healthy while we wait for the nerves to recover. So I explain it like, you know, when you're a teenager or even younger, when you first start discovering your penis, you're generally having, I think it's 7 to 10 erections through the night while you're sleeping and you're not aware of them. But that's called nocturnal tumescence, and that's your body keeping those tissues healthy while it's waiting for you to become sexually active. And then that carries on, you know, even once you are sexually active, you have this nocturnal tumescence, and it's your body's way of keeping everything healthy, whether you're sexually active or not. So when you've got no nerve supply and you're not able to have an erection, that nocturnal tumescence can't happen. So what we're trying to do is artificially provide that. So the aim is to improve or maintain the muscle function, maintain regular blood flow to the corpora cavernosa while we wait for the nerves to recover. And it can help restore penile length as well if you use the penis pumps, which I'll get to. Does that make sense? So how we do this is in my practice in our hospital, when we take before I move on, I wanted to talk about radiation. So with radiation, your damage is going to be to the nerves as well as the blood supply. So it actually, when I think about it, makes penile rehab actually very important to keep 10 minutes, okay, to keep everything healthy and to stop it from deteriorating more quickly. I just wanted to mention that before I moved on. So the tools for rehab, PDE5s, this is your Viagra type medications. We give our patients PDE5s at 2 weeks when their catheter comes out, and we ask them to take a small dose twice a week, and that just helps improve blood flow. Then you've got the penis pumps. Not everyone uses those. This is my penis pump. and it just has a pump action. And you can use that to basically pull blood into the penis and keep things working that way. That particularly helps with penile length. There are studies that say it helps, and there's studies that say it doesn't, and most urologists think it doesn't help. Physiotherapists think it does. I think it probably does, and it certainly, with a penis pump, you can actually make an erection if you use what are they called, top rings, so that these things that stretch over the pump, or this is a lasso style, so you tighten it with and loosen it with that, so you can create an erection with the pump pulling the blood into the penis and then trapping it there using the
noose
rings. And that's fairly successful. Some people do that for the rest of their sex life, and some people can't tolerate it at all, so everyone each to their own. What I would say is, if you're going to buy a pump, buy a decent one, and I've got some places to buy them from that I'll show you at the end. So that's the penis pump. And oops, did I go too far? And pelvic floor exercise. There's lots of good evidence that says that doing your pelvic floor exercises isn't only good for your urine control, it actually helps give better orgasms, and it can help the erectile function, and there are good studies that say that. So you know, the pelvic floor exercises are very good and worth doing. Moving on, so tools for intercourse, the PD5s. Once you start getting some return of erectile function, if you do, a full dose of the Viagra tablets can be used if needed. And I tell my patients, you know, to keep taking their twice a week small dose, but if they want to take a full dose now and again, and you know, just to see if things are coming right. The vacuum device, the pump with a ring, we've talked about that. We've got Cavaject injections, which this is a Cavaject injection, tiny, I don't even, so tiny you probably can't even see it, very, very tiny needle, goes into the side of the penis and gives you a very good erection. These are used for men with spinal cord injury, and they're used as a tool in theatre. Some surgeries require an erect penis and the patient is asleep, so they'll use these injections to produce that. So they are very good. They work for almost everybody. You know, they're particularly good in that it's quick and it's easy and practically instant. So they're a very good option. They're not generally given in public hospitals. They usually, you have to go to a urologist and pay to see them for that. There are a few hospitals that do Cavaject injections. One is Dunedin, I think Palmerston North. I'm not 100% sure, and we're going to be doing them in Taranaki shortly, we think. Working on it. They're a very good option, although most people don't like the idea. Now, there are also penile implants. These are only available in the private system. In the UK, they're funded for men that haven't got their erectile function back at 2 years. So you get this bit here, goes one on each side in the corpora cavernosa, and this is a little valve full of water, and there's a little switch down here in the testicles, And when you want an erection, you press your little button down here, and all of the water in that reservoir will fill up these bits here and give you an erection. When you're finished with it, you press the button and the water goes back up into the reservoir. And the reservoir just sits in your abdomen in a little pocket. That's quite successful, but very expensive. So I've actually not met anyone with one. I was in the UK. Over there they have some that are just bendy. They're just that main bulk of the body in there, and they're bendy, so the men just bend them down and put them in their undies, and get about their work, and when they want it they just bend it up. So it's very simple. But we did see a man in that clinic who liked to wear jeans, and whenever he walked downtown with his jeans, oh sorry, that was this one here, the jeans would clip the button on him, and it would go, and yeah, that was a problem.
Well, I think one of the things is, Jenny, you would have found that it's seems to be different for every man, isn't it?
Absolutely, completely different for every man. And I get frustrated with some medical professionals who think everybody is the same. They think somebody that doesn't have a partner doesn't care about their erectile function. They assume a 90-year-old man doesn't, care about his erectile function. And I've found again and again that people that everybody cares. It's whether they are motivated to do something about it is a different thing. Not everybody cares that much, but there's still a grieving process of some sort, whether there's it's part of you, and I think it's unfair to assume that it doesn't matter if someone hasn't had a partner for years and hasn't had a sexual life for years or ever. It's still, erections are still there. People still want to know they could if they wanted to. It's very important.
So I guess this is part of at the beginning, I think what I've learned is it's really important to bring your wife or your partner or the lady that's associated in your life early on, so that it's a dual participation. It's not, you're kind of not left to the side, so to speak, right?
Yeah, I think it makes it easier to start conversations at home if you've started a conversation in a clinic with, where someone's brought it up. I encourage my patients to masturbate pre-op and post-op, and so if I can tell them to do that with the wife in the room, that makes that a lot less awkward and a bit more okay and maybe normal. Right. Things like that. And even just when I was talking about saying that, what makes you a man to her, if I can say that to a patient and the wife, you'll always see the wife nodding, and sometimes people really need to see and hear that to feel a bit more okay about their situation and have a bit more hope.
Right. And there's no correlation to if you stop taking ADT, there's no correlation with PSA rise and testosterone return to those levels either, is there?
No. Sometimes when you're on ADT and the PSA levels going up, sometimes we test the testosterone, and that just tells us whether the ADT is working properly or not. Yeah. And then, usually we find that, there's no testosterone there, and then we know that the ADT's, not working. Right. And then we can add something else in. There are people out there, like people that have hair, where you get hair, what do you call it?
Oh, those follicles?
Yeah. They often, hair implants. They're often, I don't know if they're on Zoladex, but they're often on medication that reduces their testosterone. And they manage to have erections, but they lose the desire. So you sometimes you just have to work on on, you know, actively, you know, making time for sex or intimacy in that circumstance, because it's not something that's going to come sort of as naturally as it has in the past, because those desires and like I was saying, you don't get that drive to act on the feelings. So then you kind of, people in that situation need to, you know, have date night or something like that where that's something you're going to do, and it will happen, but it's, you kind of have to make it happen, because that desire is not going to drive you to stop what you're doing, and you, do you know what I mean? There's a drive with testosterone. So when you're young, you've got huge amounts of testosterone. So you'll, you know, anyone that is willing and able, you know, when you're 20, you're also willing and able. When you get older, you're willing, but you know, something else needs doing, so you'll finish that first sort of thing. That drive isn't there to drop everything and go. Oh, can I just say that if anybody wants to discuss anything privately, you can get hold of me through Taranaki, what are we called, Te Whatuora Taranaki, and just ask for me. The people will put you through, and I'm more than happy to talk to people one-on-one. I don't mind that at all.
Cool.
Just not on a Tuesday or a Wednesday, because I'm busy those days, but the other days I'm in the office. More than happy to talk.
So I'm gonna thank Jenny and for making yourself available for, you know, a really serious and key area of many men's lives. So thank you very much, Jenny.
No worries.
And on behalf of Look Good Feel Better. So it's really awesome.